Hi everyone, so I'm Dr. Shivangi, your faculty for dermatology, and today we will discuss the FMG questions that have been recently asked in the 2024 FMG. Okay, so let's start. There were not a lot of questions, and when I saw the paper, I realized that it was a very well balanced paper, at least when it comes to dermat. Like there was one question on psoriasis, one was a question from infections and infestations, there was a viral infection asked, there were pigmentary disorders asked. I think these were the main topics anyway, and all the topics were more or less touched. Okay, so let's discuss the paper. Let's see how many questions you got correct. Okay, so a young boy came to the OPD with complaints of severe itching at night. Now when it says severe itching at night, you have to immediately think of scabies. At night itching, always scabies. So now on examination, there were burrows seen over the intertriginous area, the axilla, the umbilicus and in between the digits. The disease is transmitted by. Okay, see, this is a very easy question. You came to know the diagnosis is scabies because there is itching at night. Okay, then there are burrows, again goes in the favor of scabies. Over the intertriginous area, the axilla, the umbilicus and in between digits. What is this forming? This is forming a circle of Hebra. Again confirms that it is scabies. Okay. Now it is transmitted by Sarcoptes. Sarcoptes, scabi, mite. Okay. So that is a mite. So what is it caused by? It is transmitted by a mite. And here it is the female mite usually that causes the infection. She lays eggs, around 2 to 3 eggs in a day, leading to the infection. Okay, very simple. You just have to make your diagnosis, and scabies I feel is a very easily and frequently repeated topic. So I think this should not have gone wrong. This is a very easy question. What goes in the favor is itching at night. And also the circle of Hebra is being formed. Okay, chalo, next question. A child with sore throat started developing skin lesions as in the image below. Okay, what is the diagnosis? So now when you look at the image, what do you see? These are small, annular, coin-shaped raindrop sort of lesions. Okay, so these are annular, of course they are annular. Then they are coin shaped, they're just round, okay, and maybe raindrop like lesions. Now, so there are two ways to approach this question. Either you can look at the image and you can rule out all the other DDs that have been given over here, or you can just look at the history. Child with sore throat. It is a classic case of guttate psoriasis. Why is it happening? Why is it guttate psoriasis? See, guttate psoriasis is basically caused by Streptococcus as an antigen. Okay? So usually what they give is a history of a child either getting a sore throat or getting a recurrent ear infection, after which he started developing these lesions all over the body, most common on trunk. Okay? So that is how you can either reach to the diagnosis of guttate psoriasis. That is one thing. But if you're not able to recall ki chalo child with sore throat is guttate psoriasis, what else can you do? Look at the picture and start ruling out other things. Guttate psoriasis to we know is the answer. Why is it not pustular psoriasis? Firstly, pustular psoriasis, most common in pregnancy, most common in people who were on steroids and then there was a sudden withdrawal of steroids. So usually the history will go in that favor. If that is also not given, pustular psoriasis comes with sheets of pus. The lesions will have, suppose this is the lesion of pustular psoriasis, it will have tiny pustules around the lesion, and there will be sheets of pus. This is not how the image right now, what we have, it does not look like pustular psoriasis. Okay, what is erythrodermic psoriasis? Now, erythrodermic psoriasis, more than 90% of the body surface area will be involved. Alright. And this is like an exfoliative psoriasis. So the patient actually starts exfoliating so much and there is erythroderma, which is redness all over the body. involvement of more than 90% body surface area. There will not be lesions so discrete. Now the lesions will completely merge into one another and they will form like a uniform lesion all over the body. Then you think of erythrodermic psoriasis. Why is it not inverse psoriasis? Now, inverse, what does it mean? It means opposite, inverse of what it was supposed to be. So it is like opposite. What happens is that psoriasis is a problem that you see on the extensors. It is the disease involving extensors. But inverse psoriasis, it involves flexures. And that is why we call it inverse. Inverse matlab normal jaisa hona tha uska opposite. So that is why it is called inverse. Okay? So it involves the flexures. Like your axilla will be involved. Your groin can be involved. Your intertriginous areas will be involved. And in this case, because these areas have a lot of friction, there is a lot of dislodgement of scales. Okay, and because of dislodgement of scales, when the patient comes to you, there is just redness. There are no scales. And the picture will not match because this is usually on the trunk, which also goes in the favor of guttate psoriasis, rather than being in the axilla or in the groin area, which will go in the favor of inverse psoriasis. I hope you understand this question. Chalo, let's move on. Now, third question is, a female patient presents to the OPD with complaints of recurrent lesions. First of all, it is a recurrent lesion on the lips. Now, if you are someone who has studied the subject very well, you should have two DDs immediately in your head. Recurrent lesions on the lips. Either it could be a fixed drug eruption. So I have not read the question ahead. I am just telling you from recurrent lesions on the lips. Either it could be a fixed drug eruption or it could be a herpes infection. Okay. These are the two things that will happen usually in the mucocutaneous region and they will keep recurring. Alright. Now it is associated with fever. You get your answer. Out of the two DDs, the herpes infection is also called as fever blister. Okay. So this now we know the answer is herpes labialis, which is caused by human herpes virus 1, HHV1. Okay. So now what is the characteristic feature on Zank's smear? See, this is a classic example of trying to make the question difficult when it was not difficult. Either you can go the long way where you know that recurrent infections on the lips can either be an FDE or a herpes infection. It is associated with fever and fever blister is the name for herpes labialis. And then you think of herpes labialis having multinucleate giant cells. Or what you can do is, you can simply think that Zank's smear, what does it show? What do you see on Zank's smear? This is a one-liner. This is something that you had to mug up, that multinucleate giant cells are seen on Zank's smear. Okay? So either you can go that way or you can come the long way. Now, Zank's smear, what does it show? It shows multinucleate giant cells. There is ballooning of the cells and multiple cells, they kind of fuse together. So you have multiple nuclei. So it forms like a cell like this, which has multiple nuclei. Okay, this is your multinucleate giant cell, which is seen on Zank's smear. I hope I'm making sense. Why is it not HP bodies? HP bodies is seen in molluscum contagiosum. Okay, how will that look? Those will be umbilicated, pearly white papules. Not like this, not on the lip, usually on the face. It can happen on the hands. Okay. So this everything goes in the favor of herpes labialis. I hope you understand. What are owli bodies? Owli bodies are seen in cytomegalovirus infection. Okay. It's a very easy question. Chalo. Next thing. I hope you're getting it. A 30-year-old woman, she's pregnant, okay, starts developing brownish pigmentation, which is very important, all over the face as shown below. What is the diagnosis? See, now, first clue is that she's pregnant. Second clue is that there's a brownish pigmentation over the face. What is the diagnosis? When you see brownish pigmentation on the face in pregnancy, think of melasma. Melasma in pregnancy is called as cloasma. Cloasma is basically called as mask of pregnancy. Okay, this is the answer. What happens is that melasma, it is a pigmentation disorder wherein your melanocytes are stimulated either because of hormones or because of sun exposure. It can be, there's a genetic component to it as well. Okay, because of which you have pigmentation on the cheek, on the bridge of the nose, upper lip area or on the forehead. These are the most common areas where you get melasma. Okay, so it was a straight, just you can look at the picture and you can understand that it is melasma. Why is it normal? Why is it not normal suntan? Normal suntan, you will have even pigmentation. You will not have these lesions spread on the characteristic areas. Okay, why is it not BCC? What is BCC? BCC क्या होता है? BCC में you have a nodule. ठीक है? Usually it is skin colored and usually it has beaded appearance. Okay, so that is your BCC. It is not going to come like this. It is not going to be pigmentation all over the face. It is going to be a very limited, localized to one area. There's going to be a nodule. Okay, why is it not melanoma? See, melanoma is what it happens basically on a nevus. So you need to have a picture of a nevus which has suddenly started increasing in size. It has shown asymmetry. You know, the border is weird. Then you think of melanoma. This is a very simple question with pregnancy and brownish pigmentation given. Straightforward, the answer has to be melasma. If melasma is given, it is melasma. If cloasma is given, it is cloasma. Okay, now a 40-year-old male presents with painful genital ulcers along with painful buboes. So you have painful ulcers and you have painful buboes. With a history of multiple sexual partner, what is the diagnosis? Okay, again, I will say it is an easy question, but I feel that dermatology this year was very, very predictable. These are the topics that keep coming every year. And if you don't know psoriasis, if you don't know, these genital infections, if you are not aware of pigmentary disorders, it becomes difficult to sit in the exam. So dermat is a very easy subject and it's a very scoring subject. If you've read it once or twice also, you'll be able to answer these questions. Chalo. So now this person has painful genital ulcers and he has painful buboes. Both are painful. There is a funda in chancroid which says do cry. Why? Because it is caused by Haemophilus ducreyi. Okay, so ducreyi becomes do cry. So this is extremely painful. Okay, so the answer is chancroid. If both of the things are going to pain, your ulcer in the genital lesion is paining and the lymph node is paining, that is extremely painful. Extremely painful. Who's extremely painful? The one that will cry, the do cry. Okay, so that is chancroid. Now I'll still rule out the other things. Syphilis ka funda is very hard. It is very hard. So it is so hard and strong that it is painless. Okay, so syphilis will not pain. When we come to LGV, the other DD could be syphilis only, but syphilis, because it is painless, you have to answer chancroid and not syphilis. Okay, when I think of lymphogranuloma venereum, what happens over here? So lymphogranuloma venereum has 3 stages. There's a primary stage, there's a secondary stage and a tertiary stage. So primary stage mein you're going to have papules on the genitals, okay, but these are painless. Alright, so papules on genital which are painless, that is the primary stage. So painless hote hi the painful genital ulcers just goes out, so it is not LGV. Now it has a secondary stage also wherein your lymph nodes will be involved and the lymph nodes are painful. Okay, what is herpes genitalis? You will have grouped vesicles over here. So I hope you know why is it chancroid. Chancroid, everything is paining. The genital lesion is paining. Your lymph nodes are paining. LGV, genital lesion is not painful. Lymph nodes are painful. Syphilis, not painful at all. And herpes genitalis, you will have grouped vesicles. Okay, which usually does not even form an ulcer. They are very, very superficial lesions. Alright. So now the same question, now we are done with almost all of our questions. I'm just still touching these PPTs again. These were the first PPTs and then we got some more details about the question. So a child with a history of sore throat and developing skin lesions, we just saw what was it? These were the skin lesions. It was guttate psoriasis. Okay. Why? Because it was a child and because there was sore throat. This is just a quick revision I am doing. Now painful genital ulcers with painful buboes, what is it? It is chancroid. Okay, we just saw that it is chancroid. Zangsmere multinucleate giant cells, image of the lesion on the lips that is triggered by fever, what is it? Fever blister. What does that mean? It means herpes. Labialis. Caused by human herpes virus 1. Okay. HHP2 causes genital infections. Again, brownish pigmentation on the face associated with pregnancy. What is this? Chloasma. Okay. Now there was another question wherein they said that skin biopsy of dermatitis herpetiformis was given and the disease associated with. So we have not gotten the options with this question, but I will still tell you how to reach to an answer. Suppose dermatitis herpetiformis is also not written. You just have this image. What do you see? Let me tell you a little basic about this thing. Skin. Firstly, suppose this is your epidermis. Now there are these areas over here. Okay, and below this is your dermis. So this is your epidermis. This is your dermis. What are these? This is a dermoepidermal junction. This is your DEJ. If you just expand DEJ more, you will see that something goes up and something goes down, and then something goes up and something goes down. So it is like a wavy line. Okay. We know that the upper part is epidermis and the lower part is dermis. So when the epidermis comes down or the dermis goes up, okay, what is it called? So there are two things. There are rete and dermal papilla. Now this is the dermis. So what will be dermal papilla? Dermis say dermal papilla will go up. So the one that goes up is called as a dermal papilla. And what comes down are called as rete ridges. Okay, I'll tell you again. There was epidermis, there was dermis. Between the epidermodermal area, there was an epidermodermal junction which was wavy. When the epidermis comes down, those are called as rete ridges. And the dermal papilla, it goes up, those are called as dermal papilla. So the dermis goes up, it is called as dermal papilla. Okay. So rete ridges are coming down, the dermal papilla is going up. Okay. So now you put this over here, put this on this image. You see things going up and down, up and down, up and down. Okay. So this I have explained you is the rete ridge. And this part that is going up, this part basically is dermal papilla. Okay. I'll just remove the arrow so that we see the image clear. So this part is dermal papilla. Now what is happening is that at the tip of the papilla you have this bleb like thing and there is a clear space. You understand there is a clear space over here? So what is this? This is a papillary tip abscess. Okay. Papillary tip abscess is a very characteristic thing of dermatitis herpetiformis, DH. Okay. What is over here? It has neutrophils. Okay. So that is the basic of the picture that you are seeing, that there is a papillary tip micro abscess over here that is seen in dermatitis herpetiformis. And what does it include? That abscess has neutrophils in it. The content is neutrophils. Okay. So this is the image. Now, what is the disease associated? What happens in dermatitis herpetiformis? You also need to know the pathophysiology. What happens over here is that the patient is allergic to gluten. Okay, the disease is celiac disease. So the patient has celiac disease, they are allergic to gluten. You have antibodies that are being formed against gluten that actually go and attack your papillary tip and they form microabscess over there. So this is a cross reactivity that happens. Okay. So that is why in dermatitis herpetiformis, when they ask you the disease associated is celiac disease. Alright. The sensitivity is gluten sensitivity. What are these? These are papillary tip microabscess having neutrophils. I hope I have made you understand dermatitis herpetiformis a little bit. Now, there was one more question which said that there are Lichen nodules. Where are they seen? Of course, it is a feature of neurofibromatosis. What are the other features that you see in neurofibromatosis? What is neurofibromatosis and what are the other features seen in neurofibromatosis? This one is an autosomal dominant condition. It is an inherited disorder which is characterized by, firstly, there is axillary freckling. Okay. What else is there? The cafe au lait macules. So axillary freckling, matlab you have freckles in the axilla. The patient will come with small freckles in the axilla. What are cafe au lait macules? Cafe au lait macules, cafe au lait is basically like a coffee. So these are coffee colored macules, usually more than 6 in number. They have to be a characteristic, and more than 1.5 centimeters, so they are big in size. Okay, at least one of them should be more than 1.5 centimeters. That is when you think of cafe au lait macule being a part of neurofibromatosis. They can also be seen without neurofibromatosis, but they have to match this criteria for you to call that, okay, this is a feature of NF. Okay, so you have axillary freckles, you have cafe au lait macules. What else do you have? You have Lichen nodules. What are Lichen nodules? Now these are basically nodules that are seen on the iris. Okay, so they are present on iris. They are seen in slit lamp examination, and they are basically iris hematomas. Okay, and Lichen nodules are not seen in a child. The incidence of Lichen nodules increases as you grow older. So as the person becomes say 30 or 40 years old, you will see multiple Lichen nodules. In a child, you will not find them. Okay, so there's axillary freckling, there are cafe au lait macules, there are Lichen nodules, and the name is neurofibromatosis, so there is neurofibromas. Okay, there can be one neurofibroma that is very big and that is kind of causing disfigurement, that is called as plexiform neurofibroma. Okay, so if they ask you, if they label any of these features and they say where are they seen, they are seen in neurofibromatosis. There was also a question on Lichen planus, but I am not sure what was the question. I'll still just touch the topic a little bit because we were not very clear with the options also. So Lichen planus, what can they say? They can give you either an image, but at your level you are not supposed to diagnose it just from the image. So they will mention the 5 P's of Lichen planus. Even if they are not mentioning all 5, there will be some of the P's mentioned over here. What is it? It is polygonal, it is pruritic, plain topped, purple, papules. So what do we mean by all of this? Usually these are lesions that are seen on the flexures. The person keeps itching them a lot, and when you look at the lesions, they are violaceous to purple in color. So that is when you think of Lichen planus. It is a disease of flexures. Okay. Now either they might have mentioned all of these points and they would have maybe shown a picture and asked you a diagnosis, or there are some types of Lichen planus that you need to remember. There can be either a Lichen planus pigmentosus. Over here they might mention a slate gray pigmentation. Okay, that is very important, usually seen in females, usually in sun exposed areas. Okay, it can be either an atrophic lichen planus. They can also mention actinic LP. This will be in the sun exposed areas. The actinic means sun. So it is in the sun exposed areas. And what will it be? The lesion will have central hyperpigmentation with peripheral hypo. So there is like a rim of, this is a suppose a hyperpigmented lesion. There is a rim of hypopigmentation is in actinic LP. Okay. Then what else that you need to remember in LP? So there's a characteristic lesion also seen in LP that is called as Wickham's striae. Okay, this is important. I think this is all that you need to know for LP. I'm not sure what the question was. If you guys remember the options or how the question was framed, please let me know in the comments. I'll be able to help you from there. Okay, that's it. I feel the paper was, again I've said that already, the paper looked very, very balanced. There's either a question on neurofibromatosis or there will be a question on tuberous sclerosis. One of them is confirmed. There is almost always a question on psoriasis which came this time also. Okay. Then DH, of course, a very frequently repeated topic. A disorder of pigmentation will be there 100%. Either it can be a hyperpigmentation, they ask melasma, or it can be a hypopigmentation, they may ask vitiligo or nevus of Ota or nevus of Ito, you know, mongoloid nevus. These things can be there, and a blistering disorder. This time they asked multinucleate giant cells were there, STDs were asked. Very, very well balanced paper. There are certain topics that are very important that you cannot leave before the exam. You just make sure you do that and you can score full marks in dermatology. You know, dermatology, it's very important for you to not make it wrong because nobody else will make it wrong. The questions are so easy that if you get them wrong, it's a disadvantage. You know, medicine questions are confusing. People get confused in them. But dermatology questions are very straightforward. They're very easy to be answered and it's an easy subject. Do well in it. Okay. If you have any questions, if you have any concerns, you can leave it in the comment section. I will see it at least once. And that's it. Thank you so much.